Hi there. This is just a short introduction to some of the key issues that you're going to be faced with when you select measures for assessing patient characteristics and outcomes of treatment and other types of clinical studies. And the questions that people are often faced with is how valid are self-report data that are collected from people with alcohol and drug problems. In your readings, we assigned some of the study descriptions that talk about psychometric properties and the validity of various types of information that is collected in studies of addiction treatment. And one of the things that we really need to attend to is the criticism that is often leveled at treatment outcome studies when it is claimed that people do not describe their substance abuse accurately. Often clinicians are faced with situations where patients, when they're admitted to treatment, are reticent or actually deny the use of different substances. And what we need to do is figure out under what circumstances we can get accurate information. Most of the phenomena that we want to measure in treatment outcome studies is not easy to measure by any method except by getting the information from the patient. So it becomes very important to enlist the patient as an ally to collect accurate information to the best of their ability. And there are two types of error that could come from our assessment procedures. One is random variation. So if a particular individual has a memory or cognitive deficit, or they are intoxicated, or they are not feeling well on a particular day, all of these things contribute random variation, which is called, which is a type of measurement error. We're not going to get an accurate assessment. Another type of error is systematic response bias. And this results in either someone overestimating or more likely underestimating the true response. In this case, if we're asking about their substance use, if they're being interviewed by a police officer, they're likely to deny or underestimate the extent of their substance use. In some cases, patients who are trying to get into treatment because they need help, even if they feel threatened by a relapse but are not using it, they may inflate the amount of substance use just to make sure that they get admitted in order to protect themselves. So that is called systematic error. Questions raised about verbal report methods, often based on clinical experiences and other situations where patients are highly threatened or feel highly threatened, is the idea of denial, that alcoholics deny that they have serious problems in general with alcohol, although that doesn't mean that they won't give accurate information when you ask them specifically about how much they drink. Drug addicts are sometimes considered pathological liars who don't describe their real behavior because of sociopathic personality traits. And substance users may have cognitive deficits that affect the accuracy of their recall. And another criticism is that patients often don't really understand their own motivations, and they may not be capable of giving accurate descriptions. So, is verbal report data accurate? Generally, that's not the right question. It's neither accurate nor inaccurate. It can be more accurate under the right circumstances. And those circumstances depend on the sensitivity of the information, the personal characteristics of the respondents, including whether they're sober or not, the time window of the report, whether they have to go back years and years, or whether they have to describe what they did yesterday, and the context of the situation, which is extremely important, whether it's threatening or whether it is considered by the patient to be in their best interest. And in the case of biomedical research, patients often are very motivated to give accurate answers because they know the information is confidential, they can trust the interviewer, and they're providing useful information that could help not only themselves but other people. So in summary, the accuracy of self-report data in clinical research on substance use disorders depends on the context, especially the perceived amount of threat to the individual, the type of substance, whether it's alcohol or a more stigmatized drug like heroin, the degree of confidentiality that people feel in that situation, particularly anonymity if it's a self-report questionnaire, the purpose of the questions, whether it's to determine whether they should be arrested or admitted to a treatment facility, or whether it's for research purposes, the procedure. Sometimes objective questionnaires are more anonymous and they produce better estimates of substance use. And in many cases, if we suspect that patients are not going to be accurate, we can collect the objective indicators that we spoke about in order to corroborate their self-report measures. And we can interview a significant other, a family member, to corroborate what patients say. When you have three sources of information, you can then determine whether there's consistency among them, and that helps to increase confidence in the data that you're collecting. So in summary, the overall social context plays an important role in whether self-report information is going to be accurate. That context includes respondent or interacts with respondent characteristics, the person's age, their degree of mental stability, their cognitive functioning, as well as the history of substance use that has led them to that particular treatment episode. The task variables, what they're asked to remember, their motivation, whether they're motivated or not motivated, and the cognitive processes involved in retrieving the information. All of that combines to determine whether the accuracy of their self-report information is going to be high or low.